Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. Wednesday, 24 of April, 2024, and we are really pleasured and honored to have our great speaker, Dr. Mohsen Elkossi, who is one of the Egyptian scientists outside in the UK, in Doncaster Royal Infirmary Hospital in the UK. I will leave him to speak after I will introduce our moderator, Professor Ahmed Al-Qurai'i, the head of nephrology department and professor of nephrology and medicine in Alexandria University. Professor Ahmed is known by his interest in GN kidney transplantation, and we are and genetics, kidney genetics, and we are really pleasure today to have him in one of his favorite topics in GN, which will be IgA. Before I start, I can remember I think it was the last online meeting of our late great Professor Rashad Barsoum, which was with Professor Mohsen. He was a speaker at this meeting. It was also the same like this, like today in CME chapter meetings. And he introduced Dr. Mohsen Elkossi as one of his very intelligent students from Asyut University who supervised his work in MD. And you can find this lecture recordings in our channel, YouTube channel, and you can listen to Professor Barsoum introducing Dr. Mohsen and how much he was really clever and he was really keen of every detail in his work. And Dr. Barsoum said many great words in Dr. Mohsen work at this time. And he continued, of course, his work, and we are pleasure today to have him as one of our scientists in UK. Professor Ahmed Al-Qurai'i, please, I will leave the floor to you to introduce Dr. Mohsen and lead this meeting. And our topic today will be IgA nephropathy. No more words I have. So Professor Ahmed, please start. Shukran.
Yes. Thanks, Professor Yasser. Assalamu alaikum wa rahmatullahi wa barakatuh. Bon nuit, good night, everyone. And I'm very pleasured and honored to introduce my dear friend, where we were almost a roommate. Well, actually not a roommate, but a Q block mate in Sheffield together maybe 23 years ago. Professor Mohsen is a well-known figure of nephrology in the UK. He is a graduate from Asyut University, where he had his master's degree and MD, and he had an MD in Sheffield as well, and a diploma of health science from Leeds University, UK, and he's a current fellow of the Royal College of Physicians of the UK and a consultant at Doncaster and Baslow hospitals for the NHS in UK. He is a well-known figure in Egypt as well. He always come to the clinical service in many of the public hospitals, military hospitals, in almost every and each single meeting of nephrology, of the not only the online meetings, but also this physical meeting in the Egyptian Society of Nephrology meeting and other meetings as well. And we are very privileged and pleased to have him with us tonight. And IgA nephropathy is one of his favorites. And if you can just see that IgA upon his desktop or his directory in the folder showed many years of IgA. Probably each year he updates his lecture for the IgA with the new updates. We're expecting today to hear from him about the definitely the pathogenesis and the forehead theory, the new treatment approaches with many of the on pipe or in the pipeline management of IgA, both what's FDA approved and what's waiting to be approved. And we're going to ask why we don't see so much IgA in our region, like in worldwide distribution. And I assume that we will have a lot of insight, both pathologic, pathogenetic, and management views from this great lecture. Professor Mohsen, without further ado, just go ahead, and we are very eager to hear from you tonight.
You just give me 1 second, please, before Dr. Mohsen starts. I would like to thank Dr. Mu'tasim Al-Sayed, our coordinator today, for all of his work in this session and all work in CME chapter generally. Thank you. So please, Dr. Mohsen, start.
Thank you very much for these very kind words. I'm very appreciative for the invitation, very appreciative for the warm words that I have been told now, or I have heard now from yourselves. And I believe that I have to stop here. IgA nephropathy has been done. I can't see anything that I'm going to add to what's been said. Thank you very much again. And I'm going to go as simple as I can, simply because of the difficulty of the topic, not because of the difficulty of the IgA nephropathy, because the difficulty that you are facing nowadays that we don't know exactly, although there is a lot of developments have been done within the last few years, but still IgA nephropathy is a mystery. Why it is a mystery? Simply because it is the commonest cause of GN worldwide, where the biopsy or the kidney biopsy is highly done. In areas where the biopsy is not routinely done, you might find the IgA nephropathy prevalence and the incidence, there is a question mark, it is at a low incidence. Also, the IgA nephropathy is the leading cause of end-stage renal disease in some countries, like China. For if we are talking about the causes of end-stage renal disease from glomerulonephritis. So the first person who described, as we know historically, the IgA nephropathy, and that's why we're called after his name, Berger, is a French histopathologist in 1968, and Jean Berger disease. And since then, we started to know more about the IgA nephropathy. As I mentioned, it is the commonest form of glomerulonephritis worldwide, and end-stage renal disease develops in around 20% by 10 years for those who have high risk cases of IgA nephropathy, and we will come soon to what is meant by high risk, and maybe 40% will develop end-stage renal disease by 20 years. It is a disease of the adults, but it could happen in children, it could happen in the elderly, but it is commonly in the adolescents and adults. If we look into the world distribution, you can see that most prevalent area with IgA is the Asian Pacific, and you can see that China, Japan, Korea, they are the commonest areas where the IgA nephropathy is prevalent. I usually raise the question when I come to Egypt, and I can't see that much of those patients who have got IgA nephropathy, despite of being the commonest glomerulonephritis across the world. So why it is not prevalent in Egypt? No idea, but probably because of the practice, or I mean the need of having the kidney biopsy is not practiced that frequent. But also the statistics show that the incidence of IgA nephropathy, as you can see in the Africans, very low. It is not only because of the biopsy is not practiced that much here. It is also that been done in the United States for those from African origin. They found still the IgA nephropathy from the biopsies registry less frequent than the Caucasians. So still maybe something to do with the allelic risk factors for developing IgA nephropathy is not common in the Africans, might be, but this is not clear. If we come to Egypt, I can see a paper. It's not a paper, it's an abstract, one of the editor meetings. You can see that by Professor Sarhan from Ain Shams suggested that the IgA nephropathy is around maybe 8, represents around 8% from the cause of glomerulonephritis. So still it is there, but maybe the frequency of having the biopsy, because maybe the threshold of doing the biopsy in Egypt might vary from the UK, might vary, say, for example, from Japan and South Korea. What is the pathophysiology of IgA nephropathy? As Professor Ahmed mentioned, that it is the four-hit theory. I mean, to be honest, probably from Afghan clinical trial, we learned much about this four-hit theory. What has been happening? We know that the whole mark of IgA nephropathy is defective IgA1 immunoglobulin. We know that we have got IgA1, IgA2, but the hinge region of IgA1 has got deficient galactose deficiency or glycosylation. Some people suggest that there might be some hereditary factor. Some alleles are at a high risk for developing the IgA, some environmental factors, the infection theory. All these contribute together to produce the deficient glycosylation of the immunoglobulin A, and to produce what we call it IgA1 deficient or galactose deficient IgA1 molecule, produced much at the terminal ileum. And this is what we learned from the Afghan clinical trial. Because when we use the targeted therapy of budesonide, which is released mainly in the terminal ileum, it causes a lot of inhibition of the B lymphocytes secreting this defective molecule. Once it is produced, this defective molecule will be recognized by the plasma cells as a foreign, and then will produce the second hit part by producing immunoglobulins. And these immunoglobulins usually IgG in principle, but could be IgM or IgA. And then the third hit theory, the immune complexes will form between the reaction of the two, the antigen and the antibody, and then it will deposit in the mesangium. And still a very big question mark, why the mesangium is selectively, has got a predilection for the deposition of these immune complexes. A lot of theories, many theories about that, but what is most important in this is once it is deposited in the mesangium, a cascade of inflammatory process will start, including the activation of the complement system, whether it is the alternative or the lectin pathway, because this is very important in the designing the management or designing the clinical trials to try to help with the IgA nephropathy. What are the inflammatory pathways? As we said, the most important part of the inflammatory pathway is the mucosa-associated lymphoid tissue. And the mucosa-associated lymphoid tissue, it is in the gut, as we can see, or the nasal mucosa. And that's why the tonsillectomy is recommended by certain national guidelines to be done, although it is not well known in the Caucasians, but it is well known in Japanese. And they found that the risk of hematuria, proteinuria, and the renal or glomerular proliferation is reduced with the tonsillectomy. But this is not proven in the Caucasian ancestry. And more important than that, they found also in the kidney transplant, when you do a tonsillectomy, after a year, the recurrence of the IgA nephropathy is reduced to the minimum. But it is in the renal transplant, not in the native kidney, which is very strange, and we don't know. Some people suggest that, the mucosa-associated lymphocytes, whether it is the T or B lymphocytes and the plasma cells, when they misdirected, what I mean by misdirected, instead of secreting a lot of the galactose-deficient IgA1 in the gut, they circulate and they have got defective homing receptors, and they go to the bone marrow instead of the gut, and they produce this defective molecule in the circulation, which explains why the IgA, the polymeric form of the molecule, is deposited in the mesangium, which is characteristic to the gut, not to the circulation, because the monomeric one is characteristic for the circulation or for the circulatory B lymphocytes, not for the gut-associated lymphocytes. And what they found the polymeric one, which is the gut origin, is deposited in the mesangium. And as you can see that the complement is involved, the BAF and APRIL for the B cell maturation factors are involved in the cascade, and that's why they are using inhibitor for the BAF and APRIL to treat the IgA nephropathy, and also the hemodynamic when they are using the RAS blockade and the SGLT2 inhibitor. And we have mentioned about the mucosa kidney axis, the association between the hematuria and the upper respiratory tract infection. It is very clear. Also, those patients with inflammatory bowel disease and celiac disease, they are at a high risk of developing IgA nephropathy. Again, this heightens the theory of the mucosa-associated lymphocytes with the IgA nephropathy. The mesangial deposits, as we mentioned, it is from the polymeric forms, characteristic of the mucosal IgA. The IgA plasma cell number in the gut decreases, but increases in the bone marrow. And these are the ones which are secreting the defective IgA1 molecule. We said about the tonsillectomy as another evidence. And for the mucosa-associated theory, and we said about the homing receptors, which are defective, and this might misdirect the mucosa-associated lymphoid tissue into the circulation rather than in the gut. How we diagnose the IgA nephropathy? It is a classic example. Usually we encounter many of our patients come with their just on routine screening when they have got blood and the protein in the water, in the urine. And then because they found the blood and protein, they would like to investigate what's going on. Rarely you can find some patients who are in the youngsters and they have got high blood pressure, and then they do a routine investigation to look for a secondary cause of the hypertension, and then they found active urinary sediment in the form of blood and protein. So mainly, as you can see, that it is the blood and protein incidentally found on the routine clinical when they are going for the work or the military services, and they found this by incident. There is some countries where the IgA nephropathy is prevalent. They do the urine screening for everyone, which is like in South Korea and Japan. So that's why maybe explains why the IgA nephropathy incidence and prevalence is high in these countries, because the biopsy, they have got a low threshold to go for the biopsy once they have got this active urinary sediment. There is no diagnostic tool for the IgA nephropathy except the biopsy. We have got the IgA molecule level is increased in the circulation. IgA1 is increased. Galactose deficient IgA1 is increased. The IgA immune complex is increased. But all these biomarkers are not used as a diagnostic tool for IgA nephropathy. And when we found a patient who might have or suggestive of a secondary form of IgA nephropathy, it is mandatory to just or highly recommended to go to test for his urine. Say, for example, chronic liver disease, especially alcoholic liver disease. When you have got a patient like this, you need to check his urine because he might have secondary form of IgA nephropathy. A patient with celiac disease or a patient with IPD, inflammatory bowel disease, Crohn's or ulcerative colitis, again, you might need to go to check his urine. He might incidentally have the IgA nephropathy. The IgA vasculitis or Henningsen-Lyon purpura, again, the same infection like the hepatitis B, hepatitis C, or autoimmune disorders. And I mean by autoimmune disorders, psoriasis, again, it can predispose or associated with, sorry, not predispose, associated with IgA nephropathy. The childhood, when they have had IgA nephropathy, commonly present with episodic macroscopic hematuria. And their outcome is usually favorable outcome. And this is usually clinical diagnosis. But when you found a significant proteinuria, then you need to do the kidney biopsy, even if it is in children, just to see to see whether this will need some sort of treatment or not, aggressive treatment or not. And at the same time, more important than that, how aggressive the form of IgA nephropathy, and to confirm the diagnosis. The clinical spectrum, we know that, around 30 to 40% of the young adults comes with the episodic hematuria with the children, usually following upper respiratory tract infection by 1 or 2 days. once the patient has got upper respiratory tract infection, 1 day or 2 days later, we'll have the macroscopic hematuria. 40 to 50% of the incidental finding, which I've mentioned, with the microscopic hematuria and varying degree of proteinuria. The minimum, you can see about 5%, they can present with acute kidney injury, either because of massive visible hematuria or because of rapidly progressive form of glomerulonephritis for the IgA deposits. They behave exactly like ANCA-associated vasculitis. And 5% of the cases come in the nephrotic range proteinuria. And in these circumstances in particular, we recommend to go for the electron microscopy to exclude the possibility of having podocytopathy or minimally changed disease with the IgA nephropathy. And it might be because of the secondary form of FSGS, in which case you will not find the whole criteria of nephrotic syndrome. So you will find the patient has got normal serum albumin, but just only the heavy proteinuria. Secondary forms, usually you don't differentiate between the secondary or primary forms just from the histopathology, because both of them, you have got the same histopathological feature and without any specific diagnostic differentiation between both. We know the story of the Oxford histological classification. It just, gives you or serves the purpose of having the severity of the IgA nephropathy, or when you are doing a clinical trial, you know which class we have used and what is the outcome. But to be honest, this type of classification doesn't serve any purpose for which treatment that we need to use. It just telling us might be what is the prognosis. And even the prognosis, if we look into the components of this classification, which is the mesangial hypercellularity or segmental glomerulosclerosis, both of them, they don't, predict what will be the behavior of this patient, but maybe the most important predictor will be the tubular atrophy component and interstitial fibrosis. Even the crescents, which was not one of the components when it is generated this classification in 2009, the crescents was not part of that. It just only added in 2017. And even adding the crescents doesn't add that much in terms of the prognosis. It is mainly the tubular atrophy and interstitial fibrosis. And you can see what is the classification for the mesangial hypercellularity, either M0 or M1. It is there or not there. Glomerulosclerosis, there or not there. Endocapillary hypercellularity, again, there or not there. And the tubular interstitial fibrosis and tubular atrophy, up to 25%, 50%, and 100%. Obviously, there is no 100%, more than 50%. And the crescent C1 to, again, 25, 50, and more than 50%. This is the classification. And we have got the characteristic feature, which is the diagnostic for the IgA nephropathy. The mesangial hypercellularity, with the number of cells in the mesangium is increased. And you can see here as well how many mesangia cells, more than 3 or 4. And by the immunoperoxidase, the IgA deposits. And by the immunofluorescence, you can see in the mesangial areas, the IgA deposits, which is the dominant IgA. It could be anything else like IgG. We said that there is immune complexes deposition. And the immune complexes could be the IgA, defective IgA, plus the IgG, or plus the IgA, or plus the IgM. And with the electron microscopy, which will be important in case of the nephrotic range proteinuria, just to verify or exclude the podocytopathy or minimal change disease. As you can see, this is the capillary loop with the endothelium and outside the podocytes. And then here you can see the mesangial cell, and this is the mesangial deposits. Very clear, and the mesangial deposits adjacent to the capillary loop. What is the, now this is a very important one. What is this international IgA nephropathy prediction tool? This is the tool that, you can calculate it by just going to the App Store, and you find this, what we call it, calculate by QXMD. It can calculate for you the prediction tool, or just Google it. And what you need in this tool, you need just the age of the patient, the race, the EGFR at the time of the biopsy, at the time, or within 6 months, maximum 6 months. You can't do this prediction tool beyond 6 months from the biopsy. The level of the proteinuria by the urine PCR and blood pressure at the biopsy time, whether the patient has been on RAS blockade or not, and what is the MCIT-C score for the Oxford classification score on the biopsy, and whether they have used the steroid or not. What is the value of this tool? It gives you the prediction of the 50% drop of end-stage renal disease or development of end-stage renal disease, 50% drop of the eGFR or end-stage renal disease within 5 to 7 years from the biopsy. It doesn't give you more than or beyond the 7 years, and it doesn't give you anything else apart from the 50% reduction of eGFR or end-stage renal disease. What is the validity of this tool? It is clearly in adults, doesn't work in children or in the secondary forms. It's mainly for the primary. And we have got two versions of this calculation, one for the Caucasians and Asian, which is very prevalent, and one for the other races, which we can just use to predict the prognosis of the IgA in this patient. Unfortunately, this tool, again, like the Oxford classification, doesn't guide any certain treatment. We can't say that if, say, for example, the prediction is 50% or less than 50% or 30%, we can't say which type of treatment that will suit this particular patient. We said about the biopsy is the main thing to diagnose. The differential diagnosis of IgA dominant, when you see in the immunofluorescence or immunoperoxidase, the IgA deposits, either the primary IgA nephropathy or any of the secondary forms. And we mentioned the secondary forms, including the vasculitis or Henoch-Schönlein purpura, secondary liver cirrhosis or viral infection. And we said about the viral infection, hepatitis B, C, HIV, autoimmune disease like the psoriasis or inflammatory bowel disease or celiac disease, or IgA dominant infection. There are sometimes you have got some bacteremia or septicemia or Staphylococcus aureus, which is the commonest to cause IgA deposits. And I mean, this is a very high risk cases and it ends up with mortality, and usually particularly in the diabetics. How to differentiate it? Clearly, they behave completely different from patients with IgA nephropathy who can just live for years, but these patients with the Staphylococcus bacteremia or septicemia will just deteriorate very quickly. What about the treatment? The treatment of IgA nephropathy, as we can see in the KDIGO guidelines in 2021, the best supportive care for 3 to 6 months to achieve proteinuria less than 1 gram per 24 hours. Clearly, they aim for no proteinuria because the proteinuria is the whole prognostic marker for deteriorating kidney function. What are the elements of the best supportive care and from where they drag the importance of the best supportive care? The elements of the best supportive care is the lifestyle modification. So weight reduction, blood pressure. I believe that the blood pressure of 130/80 is high. And usually we are looking for a blood pressure of 120/80 millimeter mercury, particularly with the higher proteinuria. Less salt intake, around maybe 2 grams of sodium salt intake a day. Smoking cessation, exercise, particularly the aerobic exercises, not the lifting exercises. Usually use the maximum tolerated dose, regardless even of the blood pressure. Obviously, we are not going to go for hypotension, but if the patient is well controlled with the blood pressure and didn't reach the maximum dose of RAS blockade, we can increase it for the purpose of reducing the level of proteinuria to be less than half a gram. Why that? Because the 1 gram or more is considered a high-risk patient and can deteriorate the kidney function quite quickly. SGLT2 inhibitor is not included in this KDIGO guidelines. And I am sure after the Nefigan, the budesonide target release, and after the endothelin receptor 1 antagonist approval by the FDA, this will be updated soon. Maybe in a few months' time, they will update these guidelines for the treatment of IgA nephropathy. We need to address the cardiovascular risks. And if we are talking about the cardiovascular risks, it's mainly the lipids and the two modest decrease in the daily protein intake. So what are the high risk patient? As we mentioned, it is those with a proteinuria for more than a gram per 24 hour, and usually we use for the supportive care for 3 to 6 months. And if they failed to drop the proteinuria less than 1 gram, then we need to look into something else to help with the proteinuria or better prognosis of those patients. As we mentioned, neither the prediction tool nor the Oxford class would recommend specific type of treatment for those patients. And what they recommend, any patient with eGFR less than 30 ml per minute, usually we go for best supportive care. Why is that? Simply because the steroid management in the 4 clinical trials we have in steroid treatment didn't include that much people with eGFR less than 30. I mean, in the testing trial, which is the highest of them, containing those patients with less than eGFR of 30, there were only 26 patients. So we can't predict whether those patients with eGFR less than 30 will benefit from the immunosuppression or not. That's why we are saying that patients with eGFR less than 30, still we don't have any evidence to give them any immunosuppressive medication, and we go for the best supportive care. I mentioned before from where we could get the importance of the best supportive care. It came from the clinical trial of steroids called Stop IgA. What they have done in this trial, it is a trial when they have tried the steroids and the 2 arms, the other arm was the best supportive care, and they found that after 3 years from the trial, they found those who are in the best supportive care drop down their eGFR by just only 4.2 ml per minute. This means that the best supportive care can achieve what we are looking at. And they didn't find in this trial, Stop IgA Nephropathy, they didn't find any benefit from the use of the steroids because it reduced the proteinuria, but it didn't translate after 7 years, not only 3 years. After expanded time of follow-up, they didn't find any benefit on the outcome of end-stage renal disease on those patients received the steroids compared to the best supportive care. That's why the KDIGO guidelines, they are very keen for the best supportive care for all patients for 3 to 6 months. Now, what about those, 50 mils to 30 mils? This will be depending on the patient. Say, for example, if the patient is going to be, and the high risk, obviously, we are talking about the high risk patients now. So between 30 and 50 mils per minute of the eGFR, if they are obese, have got metabolic syndrome, have got background history of TB or HIV or hepatitis, at risk of developing diabetes or osteoporosis, elderly, more than 50 years old. In these cases, I would be doubtful that they will benefit much from the steroids. Probably, if they benefit, they can go with the problems of the steroids, which I have mentioned now. So probably the steroids might not be the best possible option in this case between 30 and 50. More than 50, eGFR more than 50, yes, you might be able to go for the steroids if the proteinuria is more than 1 gram, particularly if there is any renal impairment. We will come now to the pitfalls of this trial of the Stop IgA and the testing trial. Why there was no difference, because the testing trial found some difference between those who received the steroids and those on the best supportive care. And we'll come to this in a minute. So the steroids trial, there are 4 trials. The most important of them, the Stop IgA and the testing. Stop IgA was 2015, testing was 2017. Stop IgA was for the Caucasian only, and testing were for the Chinese, Korean, and Japanese. Stop IgA were just only 270 patient participant. For the testing, planned for 750, but terminated early because of 2 cases of death from the steroid dose, simply because they used the highest steroid initially. And the highest steroid, it was around maybe 0.8 milligram per kilogram body weight of methylprednisolone, with the maximum dose of 48 milligram a day. And this is for 2 months, followed by a monthly reduction by around 8 milligram every month for 6 months in total. And they found that those patients, after probably 300 patient recruitment, 2 patients died, so they have terminated it at this stage. And what they have done, they have reduced the dose of methylprednisolone to be, instead of 0.8, to be 0.4, milligram per kilogram. And they have not published, I mean, it was, I mean, in the Kidney Week in 2021, they mentioned their outcome for 503 patients when they have reduced the methylprednisolone dose, and the maximum dose, not 48, 32 milligram, and they have used also a prophylaxis of cotrimoxazole for those patients because of the PCB or BGB infection. What they found? They found that the hazard ratio of the primary outcome, what is the primary outcome, was either to develop end-stage renal disease, or 40% reduction of the eGFR, or death because of renal failure. And this nearly the primary outcome for both, for the stop IgAN and for testing. And the testing after, as I'm saying, after 370 participants, they found that the hazard ratio is reduced by around 37. 0.37 the hazard ratio, which is excellent for those who have got the steroids compared to those who are on the best supportive care. When they reduced the methylprednisolone dose to be 0.4 milligram per kilogram per day, the good benefit of steroids is still maintained. And after analysis of 503 patients, they found the hazard ratio of 0.53 with a risk reduction of around 47% in the primary outcome. But if we can compare both of them, you can see that the baseline proteinuria for stop IgAN was just only 1.6 to 1.8 gram per day. The patients with the testing, the baseline proteinuria was 2.5 gram. So they are at more worse compared to the stop IgAN. Again, those patients in testing on the placebo arm, they have lost around 7 ml per minute per year of their eGFR, which means that they have got more aggressive forms of IgA nephropathy. And don't forget that we are talking about completely different racial ancestry in terms of the testing or stop IgAN, Caucasian versus Chinese or Southeast Asian. So there is benefit from the testing, clearly, from the use of the steroids, even at the reduced dose of the steroids. For those patients with heavy proteinuria, if the best supportive care didn't help reducing the proteinuria to the minimum, and I mean by the minimum, less than 0.5 gram per 24 hour. But take into consideration all what we have mentioned in terms of the side effects of the steroids and the toxicity, including the diabetes and all we are familiar with what is steroids can cause with the cardiovascular problems. These are the steroids treatment. And this is obviously the KDIGO guidelines, and they stopped at this point, the KDIGO guidelines, because we haven't got the results of the other clinical trials, IFGAN or the PROTECT trial, which we will come to in a minute. Specific forms or variants of IgA nephropathy, how we can treat them. Rapidly progressive form, we treat them exactly like the ANCA-associated vasculitis with cyclophosphamide, but you need to see in the biopsy crescents, maybe more than 50%, and rapidly progressive or deteriorating kidney function. Nephrotic syndrome, mentioned that we need the electron microscopy to exclude minimally changed disease, and if there is any minimally changed disease with effacement of the podocyte and the podocytopathy, go ahead with the steroids as if you are treating minimally changed disease. Acute kidney injury, we said about the frank hematuria, can cause acute kidney injury, or ATN, acute tubular necrosis, and the worst prognosis for those cases, if they have got heavy proteinuria before, if they have got heavy hematuria in the past, or those with the patient with age more than 50. Usually they carry worse prognosis. And if they didn't recover within 1 or 2 weeks, I mean, the prognosis probably will be grim. IgA vasculitis, which is the Henoch line purpura, I mean, doesn't predict the presence of active urinary sediment or IgA nephropathy. And then you might need to do the urine testing and to do the biopsy if there is any active urinary sediment. Steroids will not prevent the glomerulonephritis to develop in these cases. If you give the steroids for the skin lesion, this doesn't mean that they will not develop IgA nephropathy. We said that there is no biochemical marker for the IgA diagnosis. Sometimes we can use the MMF, but only in the Chinese people, not in the Caucasian or other racial ancestry. Japan, the tonsillectomy, as we mentioned, there are some recommendation about the tonsillectomy, but not in the context of other cases. Children, the relapses are common, and the treatment of steroids may be initiated early to avoid the development of end-stage renal disease, because it will be indolent course depending on the level of proteinuria. NefIgArd clinical trial, which is published in 2023, budesonide 16 milligram a day for 9 months for those patients with eGFR more than 35 ml per minute, and the proteinuria more than gram, which is the high-risk patient. And they found that the proteinuria level has dropped down, and the eGFR difference between those on the best supportive care and the budesonide was around 5 ml per minute difference within this 9 months. And they have just, published their 24-month follow-up, and they found that the eGFR after stopping the budesonide after the 9 months is still maintained and translated into better outcome and better patient quality. What are the side effects of the targeted release budesonide? Is the edema, hypertension, muscular spasms, and the headache. And I can add to this the cost. The cost is expensive. This is the budesonide or targeted release steroid. Usually it is released at the terminal ileum, where the main problem of the IgA nephropathy caused the trouble. What about the sparsentan and versus irbesartan in IgA nephropathy, the PROTECT trial? Sparsentan is a selective endothelin-1 receptor antagonist and angiotensin receptor antagonist. And in a 400 patient, over 2 years of a treatment of the sparsentan versus maximum tolerated irbesartan dose, there was an eGFR difference between this one and that one by around 1.1 ml per minute per year, the difference. But more important is that the proteinuria difference between both was around 40%. So the proteinuria in the sparsentan arm dropped down by around 42%, and then the irbesartan arm was around 4.4%. So it's a 40% difference. And we know that the proteinuria is a surrogate marker for the deterioration of the chronic kidney disease. There was no safety signal, and it is FDA approved like the budesonide. And these are the two selective anti-IgAN medication so far. What are the future trials? And I'm going through the trials. As we said, that we have got the atrasentan, which is selective E1 receptor antagonist, and the Novartis, I believe, they published their interim results just only a few months ago, and said that for those patients with the proteinuria more than 0.75 gram, they found that the atrasentan dropped down the proteinuria significantly compared to the placebo arm, and they are going to for the accelerated approval pathway in the FDA to approve it for the treatment of IgA nephropathy. There is another trial for the lectin pathway complement inhibitor, narsoplimab. Also, there is one for the alternative pathway inhibitor, iptacopan. And we have got one which will start soon for the raluzimab, which is the C5 inhibitor in the complement, and will start probably maybe in July, in June time. We are participating in this trial, by the way. So hopefully we will find something coming on the horizon. There are some trials, obviously, about the hydroxychloroquine. They found that in the Chinese patients, it reduces the proteinuria, but we don't have long-term outcome about these trials of the hydroxychloroquine. We have also some trials ongoing now about the use of the finerenone on those patients with non-diabetic proteinuria to see whether they will make any difference at all or not. Thank you.
Thanks, Professor Mohsen, for the excellent review and the holistic view of the IgA from the creep to the cane. Actually, we went through the pathogenesis, pathology, prognostic markers, management plan, expected prognosis, and the treatment on the ground and in the pipeline. And before going for some of the comments on the chat, I'd like to pose some questions and share your experience about these points. First, you've alluded to the difference, maybe geographical or racial difference between the IgA, whether it is related to the poor biopsy take in some countries or the actual change in the pattern. Actually, here in Egypt, we had maybe 3 or 4 series of assessing the different types of glomerulonephritis in our Egyptian population, and almost always the IgA was not ranking neither 1, 2, 3, or even 4 in the course of the glomerulonephritis, although mesangial proliferation was always there as well. So is it genetic, as it was mentioned, that to have this galactose deficient IgA nephropathy, you need to have a genetic predisposition in the first part? And the other thing that's related to this point as well, why we differentiate secondary from primary IgA, although both are related to the gut manipulation of the IgA, I mean Crohn's or ulcerative or even cirrhotic glomerulopathy with the bypass due to cirrhosis and flooding of the kidney with IgA. It's at the end is IgA originating from the mucosa, from the gut, exactly like the same in primary IgA. So what's your take for these points?
Thank you very much for the excellent questions. First one is probably I might rebounce back with another question. I'm not sure about the biopsy in Egypt. Are we doing usually the immunoperoxidase and immunofluorescence in all biopsies, or just the light microscopy? Because this can affect much the diagnostic criteria for IgA nephropathy. But even if it is being done, and it is, the statistics is based on the immunoperoxidase or immunofluorescence, then, as I mentioned, even in the areas that there is no much practice of the biopsies, in the African American, when they looked into the biopsy registry, they found that the incidence of IgA nephropathy, those coming from Africa, far less compared to the Caucasians. And there are some risk alleles in terms of the genetic. They found it more prevalent in the Caucasian and Southeast Asian compared to the African Americans. So might be it's a combination of both, either the genetic one, and probably the other issue is about the practice in terms of the biopsy. This is probably my explanation, but you might there might be another explanation which I'm not aware of. As regards the second question, you mentioned why we are, differentiating between the secondary and the primary. Clearly, is just in terms of two things. A, the prognosis, because the prognosis in the secondary cases will be dependent on the cause of the IgA deposits, not on the IgA itself. So if you have got, proteinuria or deposition of the IgA in the kidneys of a patient with cirrhotic liver, alcoholic liver disease, then the prognosis will depend on that. And also the treatment will depend on the treatment of the original cause, which is the cirrhosis or the inflammatory bowel disease. This is probably that's why we are concentrating on the importance of the secondary causes of the IgA nephropathy. But in any case, if you have got a patient with the criteria of poor prognosis or high risk with a proteinuria more than gram, still I will treat him exactly the same like IgA nephropathy.
Thank you, Dr. Mohsen. Thank you, Ahmed, for these illustrations and for your comments. I have, let me take your last comment, Dr. Mohsen, and go to one question of the chat from Dr. Abdelhamid Amin, and then the Professor Amr Al-Husseini will comment.
Okay, go ahead. please. Hello? Hello?
Dr. Yasser, are you there?
I am there, but I'm not sure. I mean, I can't hear anything now.
I don't know why Yasser, probably we lost Yasser's voice. So till
You
Yasser
cannot,
come back,
you
would I
cannot
ask
hear
you?
me?
Yeah,
Yeah,
now I
now
can
we
hear you.
can.
Yeah,
Now we
I can
can
hear
hear
you
you.
now.
Yes. Yes, okay. From Dr. Abdelhamid Amin, he is speaking. I will take your last words about prognosis. He is speaking why patients with macroscopic hematuria has better prognosis than patient with microscopic hematuria.
Sorry, macroscopic or visible hematuria, better prognosis
Yes,
than the better prognosis than.
microscopic.
To be honest, the prognosis, it depends on the presence or absence of the proteinuria. A, presence or absence of high blood pressure. B, presence or absence of worsening kidney function. So it is not only the microscopic in isolation, and the macroscopic hematuria, as we mentioned, that it can cause acute kidney injury, the macroscopic hematuria. But I mean, and the macroscopic hematuria encountered more in the children compared to the adults, and the children prognosis is usually better than the adult prognosis.
Okay, let me ask you a question for myself.
Yeah.
You said the patient with macroscopic hematuria or acute kidney injury needs close supervision only. I get that you treat it as a post-infectious type. Is it real?
Sorry, what the post-infectious type? No, what I mentioned that
No,
there are some cases. There are some cases of IgA deposits in the mesangium with the associated with the Staphylococcus bacteremia, and these cases are post-infectious rather than IgA nephropathy, and you will find the humps of the post-infectious, but you can see very prominent IgA deposits, and the prognosis on those cases is very poor, particularly if they are diabetic or more or elderly. Mortality rate is very high because of Staphylococcus septicemia or bacteremia. And they are not considered IgA nephropathy. It's a post-infectious secondary to the bacteremia or septicemia of the Staph aureus.
Okay. So Mohsen, what's your take about the pleomorphic presentation of the clinical picture of IgA nephropathy? I mean, why is it not like the lupus classes, where it can come with a FAKD, with an AKI, with a vasculitis, with a nephritic, with a nephrotic, with asymptomatic proteinuria, with the isolated hematuria? It can present with any clinical syndrome or presentation of glomerulonephritis. So why we're not taking that as classes and managing the presentation per class like we do in lupus?
I believe that comparison with lupus is completely different, simply because, I mean, in lupus, we know the types of the rapidly progressive or not rapidly progressive or membranous or whatever it would be. But for these cases, if you look into it, most of the cases, as you mentioned, most of them, they come incidentally by just finding someone who has got incidentally blood and protein in the water, indolent course for over years, and the kidney function is slightly impaired. And to be honest, even in the UK, we don't biopsy those patients if the proteinuria is less than 1 gram. We just, closely monitor them by just doing the urine ACR every 6 months, best supportive care, RAS blockade, SGLT2 inhibitor, tight control of the blood pressure. And if they deteriorate the kidney function or proteinuria getting worse, then we go for the biopsy. So the percentage of those coming with rapidly progressive glomerulonephritis is around just only 5%. And those coming with the severe form, like, say, for example, the nephrotic syndrome, 5%. But if you talk about lupus nephritis, 50%, they come in class 3 and 4. And they are very changeable in the lupus nephritis. And we know very well that the prognosis of the class 3 and 4 in lupus will be very poor prognosis. And they need a specific treatment. In IgA nephropathy, we don't have that much information about, except this prediction tool. About that, we can say that the end-stage renal disease or the 50% reduction in 5 to 7 years will be how much? We don't have that much more than that. But lupus, we studied it very well. and we know the specific treatment, and we know that it relapses very frequently, not like the IgA nephropathy. So I feel that the IgA nephropathy, the lupus nephritis is a disastrous disease compared to the IgA nephropathy, if we are talking on the bulk of the IgA nephropathy.
Yes.
Okay, let me ask a question, Dr. Ahmed and Dr. Mohsen, about in your clinical practice, do you find much more change in clinical presentation within the same patient like lupus, as Dr. Professor Ahmed said? And if you find this frequently, or you find this somewhat frequently, what are the factors that you can expect a change in the clinical presentation or a change of histological pattern leading to a change in clinical presentation in patients with IgA nephropathy?
Okay, to be honest, as I mentioned, most of the patients, they present with the proteinuria, microscopic hematuria, mild impairment of the kidney function, marginal increase of the blood pressure. And they behave like this up to the end. What I mean by up to the end will be a progressive increase of the proteinuria if the best supportive care is not helping, and worsening of the proteinuria. And with the worsening of proteinuria, the question will be, if this is a secondary FSGS because of the progression of the glomerulosclerosis, or because of the poorly controlled hypertension, or it is just a nephrotic range proteinuria because of minimal change, which is not the case. But if they present it from the start with rapidly progressive glomerulonephritis, most of the cases, they are not saved, and they end up into end-stage renal disease, particularly if they are males.
Okay. Yeah, so you can't find much more change in the histological and clinical picture. Professor Faisal, yes, thank you.
Mohsen, excellent talk as usual.
شكرا جزيلا. شكرا جزيلا. ازي حالك يا دكتور فيصل؟
Alhamdulillah. Just I wonder why we have this incidence of IgA nephropathy in the last years, many years before, and then we start now to speak about IgA nephropathy. Is there any demographic changes or any epidemiological changes in our area, or it is diagnostic tool which we don't have it before, like biopsies and
in my opinion, the best thing that we have over the last few years is the pathogenesis, and we have got some sort of understanding how the IgA could be treated. And that's why we have got plenty of clinical trials now, and we have got approval of some medication which is specifically designed to treat IgA nephropathy. And we know that the IgA nephropathy is the leading cause of end-stage renal disease in the Western societies and Southeast Asia. And I believe that they are successful now in managing this disease.
Yes, but you agree with me that we were under-diagnosed IgA nephropathy in our area here? Probably
we still I believe we're still doing the same. And I have raised the question to Professor Ahmed, whether when we do the biopsy, we are just relying on the light microscopy only, or we are also using the immunoperoxidase and the immunofluorescence, which is the gold standard for diagnosing the IgA nephropathy. I don't know. I mean, the answer
actually we use immunoperoxidase for almost every single patient for at least the last 7 to 10 years, and we had these series coupled with Professor Wissam Ismail, more than 850 patients. IgA nephropathy was ranking like number 4 or 5 in the causes of GN in Egypt. So
and probably Professor Ahmed, maybe many of those cases are secondary with the infection. Say, for example, Hep C or bilharziasis. So it might not be all of them primary IgA nephropathy.
Yes, this is another take. Yes, this is. I'd like to pose another very crucial question that I can't find an answer for, although I searched for with the clinical pharmacist. Probably I got an answer that is not so much convincing. You know, we have for a long period of time budesonide as a treatment for IPD.
Yes.
and it was and it is actually very cheap in comparison to the Tapiril or the Nafcon or whatever you call it, which is again budesonide with a local release form for the virus patches to act upon, which they call it TLR or whatever they call it. So does the change in the pharmacokinetics to attack the Bayer patches, although it should be the same as well in IPD, does it need that much difference in the cost, or could we try the old form in treatment and management of IgA? What do you think about that?
To be honest, there are many people, they have tried the budesonide for either for the COPD or for the inflammatory bowel disease, but without the correct dose. Now we know the correct dose is 16 milligram, not 9 milligram, not 8 milligrams. So we know now that what is the right dose. But also it seems that the release of the budesonide, this is what we've been told by the companies, that it is just mainly in the terminal ileum, where the main problem is happening with the IgA nephropathy. Whether this is true or not, no idea, and I don't have an answer. But definitely the cost is a very important thing, but you can try it, and there are a lot of case series that they have used the old or generic form of budesonide used for inflammatory bowel disease or used for the COPD.
Thank you.
Okay.
Thank you, Dr. Ahmed. Before I take Dr. Amr Al-Husseini, I can take a question from the chat from Dr. Khalid Abu Zaid is asking why proteinuria is a specific prognostic marker while hematuria is a diagnostic, not prognostic marker. And I think he is asking that proteinuria is specific for IgA, not for CKD in general. And another question that regardless of the daily pathogenesis theory, what is the best treatment option beside C5 inhibitors?
It is a series of questions. So which one I'm just going to start? So first of all, why the proteinuria, not the microscopic hematuria? Because from the epidemiological studies, that it is well known that the proteinuria is a surrogate marker for the development of end-stage renal disease or deteriorating kidney function. We know that the microscopic hematuria, it should in theory carries a benign prognosis, although some people, they say that now, no, it doesn't in all cases carry benign prognosis. Still, it might cause a problem, but if it caused the problem because of the proteinuria, not because of the microscopic hematuria. So still we know from the epidemiological studies that the albuminuria or proteinuria is the surrogate marker for deteriorating kidney function. And that's why treatment of the albuminuria or proteinuria is crucial in diabetic nephropathy in any form of glomerulonephritis. So this is the first question. The second question I forgot. Sorry.
The best treatment option.
C5. No, C5 is not the best treatment option for IgA nephropathy, simply because it's the most expensive treatment, and we don't have the evidence as yet to say that we are going to start the relizumab in July for a trial which will end up in 2027, I believe, the last participant, and then will be the analysis. So, and this is a long-acting form of the eculizumab. And both of them, they are very, very expensive drugs. So it is not the case of the best specific treatment. Treatment for IgA nephropathy is best supportive care if the proteinuria less than a gram, or if it is even more than a gram for 3 to 6 months, and we'll see and reassess after the 6 months. If the proteinuria is still more than a gram, then you need to think about the patient, whether he has got any risk factor, if he used the steroids or not, and how much is eGFR. Is it more than 50 or between 50 and 30 or less than 30? Less than 30, still carry on with the best supportive care. 30 to 50, any risk factor for osteoporosis, diabetes, obesity, or whatever it would be, or more than 50 years old, don't go for steroids. If it is more than 50, go for steroids, probably the budesonide or sparsentan, this or that. Obviously, the evidence we have got now from the budesonide, because it assesses the eGFR and the proteinuria, but the sparsentan, although it is for 2 years, but assessed only the proteinuria. And the eGFR was not that great in terms of the drop, and also the follow-up is still short, 2 years, we can't say anything about a disease which can cause end-stage renal disease within 20 years.
Thank you so much. Professor Amr Al-Husseini, please.
Right?
Thank you so much, Professor Yasser and Professor Ahmed Al-Qurei, for moderating the session. And thank you so much, my dear brother Mohsen Elkossi, for this fantastic presentation. I'm here to learn. I don't have anything to add, but if you allow me just to ask very quick questions. We know that the galactose deficient IgA serum level doesn't correlate with the disease severity or the prognosis. But what about the intensity of the IgA deposition in the immune fluorescence? Does it have any prognostic or diagnostic impact or correlation? Does it correlate with the severity or the prognosis of the disease? That's my first question. Second question, for the therapy, I just want you to highlight a little bit on the SGLT2 inhibitors. If there is any subgroup of patients who might be benefit from this class of medication. And also, when we ask about the complement inhibitor, because we know that in IgA nephropathy, there is alteration in the lectin and in the alternative pathway. So we are not talking about the eculizumab, which is an injectable form, but the newer oral forms like avacopan and iptacopan and the other newer complement inhibitor. Would it have any potential effect in IgA nephropathy?
Thank you very much, Professor Amr. First of all, in terms of the intensity of the immunofluorescence, there is no consensus about that the intensity correlates with the severity of IgA disease. Probably because this intensity could vary from one histology to the other, probably the preparation. As you know, that the intensity of the immunofluorescence is not uniform or universal in terms of the preparation. So probably this is the reason, but clearly there is no evidence to say that the intensity of the IgA deposition by the immunofluorescence correlate with the severity. And don't forget that this, at the end of the day, it is very subjective. Someone can say that it is 2+, and another can say that it's 3+. So what is the difference between 2+ and 3+? You can say that interpersonal difference is huge. So I believe that maybe this is one of the reasons why they are not considering the intensity as part of the correlation with the prognosis. In terms of the treatment, the trial of the raluzumab, which is one of the C5 inhibitors, is started to be, as I'm saying, in July. We are a center and I'm principal investigator for this trial in my center. And they are recruiting until 2027, and it is with the lupus and IgA nephropathy. And by the way, that, I mean, probably it is because this is a single injection, not like the eculizumab. And they are claiming that it will, in the phase 2 trial, has got very good results in terms of the proteinuria and in terms of the EGFR. And don't forget, at the end of the day, the lectin pathway or the alternative pathway, they will end up by having the C5 probably activation. So that's why maybe they are thinking about the C5 inhibitor might help with the membrane attack complex. At the end of the day, raluzumab, when they are using it, it will be every month or every couple of months to give the injection. About the oral preparation, avacopan or iptacopan, still the trial ongoing. Still, we haven't got the results as yet, as far as I understand. All what we have got so far is the E1 inhibitors, whether it's sparsentan or atrasentan. And the atrasentan is still even not yet approved. And as I'm saying, Novartis, they were claiming that they will apply for accelerated type of approval from the FDA for the atrasentan.
What about SGLT2 inhibitors? Do you think?
Yes. You know that the SGLT2 inhibitor, when they started to think about it after the DABA-CKD, when they found that 67% of the, 32% of the patient, they are non-diabetic. And most of those non-diabetic were either hypertensive or IgA nephropathy. And they found that those patients, they are behaving exactly like the diabetic, might be a slightly lower compared to the diabetes. And the same came from the IMBA kidney. So I believe that any patient with IgA nephropathy with proteinuria, whatever the level of the proteinuria is, and there is no contraindication for SGLT2 inhibitor, I will go for SGLT2 inhibitor simply because to retard the proteinuria or antiproteinuric effect. And as I'm saying, the KDIGO didn't add it because the DABA-CKD publication was not available when they have just published the KDIGO 2021. And that's why after the budesonide and after the sparsentan and the SGLT2 inhibitor, I am sure KDIGO will soon change or update their management of the IgA nephropathy.
Thank you, sir.
Thank you so much. Question, I think, Ahmed and Dr. Mohsen both, from Dr. Muhammad Abdelbari. He is asking about sparsentan, if it can be used as an antiproteinuric drugs.
To be honest, Assalamu alaikum, Dr. Muhammad.
Antiproteinuric in general, not for IgA.
Yes, I understand. Maybe Professor Ahmed would like to comment, or shall I
No, go ahead, Professor Mohsen.
Yeah, I mean, to be honest, I mean, the evidence we have so far is for IgA nephropathy. It is, I mean, theoretically might work because it works on both the angiotensin receptor and the endothelin-1 receptor. But we don't know what is the impact on other types of proteinuria. Don't forget, finerenone is working in diabetic nephropathy, but we can't use it in proteinuric IgA nephropathy. And they are doing a trial now on the finerenone for the IgA nephropathy or non-diabetic proteinuric patient. So I can't say that sparsentan, we can use it in terms of any proteinuria other than the IgA nephropathy until we have got evidence.
Okay. A question from Dr. Asma, asking about Asma Khodr, asking about disappearance of IgA deposits by years. If you do during a biopsy, can we find the deposits disappeared? And she augments her question by a case that she faced with patient by kidney biopsy in past IgA nephropathy, and after 4 years, we repeat the biopsy and show no IgA deposits. What's your comment? Is it usual for this, or is it needs an explanation?
Probably, to be honest, it might be a secondary form of IgA nephropathy because of an ongoing infection, like the ones that we have mentioned, and why the, I mean, disappearance of the infection, the deposits started to clear. Don't forget that we have got plenty of patients with IgA nephropathy, and they are transplanted, and you can find the deposits on the histopathology level, but not translated into deterioration of the kidney function. And they are still have got the deposits there. Doesn't mean that, and not that only, we have got in the general population IgA deposits in around 4 to 16% of the general population, which is very interesting, but doesn't mean that there is a proteinuria.
Okay. Thank you so much. Another question from Dr. Abdelhamid Amin, and I think sparsentan is the star of this lecture beside Dr. Of course. Asking about sparsentan. Why sparsentan improves proteinuria in IgA, but no effect in FSGS in spite of improving proteinuria with the drug, but not the same role in FSGS. And Professor Ahmed, of course, if you have a comment after Dr. Mohsen, we would be so pleased.
Sorry, I couldn't hear the last comment. Sorry.
Sparsentan.
Yeah.
About sparsentan role
efficacy in IgA, but not in FSGS.
Not FSGS, in spite of having an effect on proteinuria.
Yeah, I don't know the answer. So this is the I don't know the answer, but I mean probably because in the FSGS you have got the glomerulus. The glomerulus is damaged already, and I'm not sure whether they are going to do any improvement of the damaged glomerulus or not. I don't know, but I mean the answer, I have to admit, I don't have the answer.
Okay, thank you, Professor Ahmed. Can you do you have any explanation for this?
No, actually, I really go for the explanation by Professor Mohsen. The problem with FSGS that the sclerosis have started and is going on, and as you know, FSGS is also a pleiotropic presentation. Very big part of it is secondary to evolving hyperfiltration and loss of other parts of the nephrons in the kidney. So probably it's too late to start with these drugs. That's why the hemodynamic effect that we use with ARBs and SGLT2 inhibitor might preserve the kidney function for a longer time, but it does not reduce the inflammation or the not the inflammation, the scarring process. While in IgA nephropathy, as Professor Mohsen showed with the MEST-3 score, that the most prognostic value is related to the IFTA, or the interstitial fibrosis and tubular atrophy. And that's why it is when you interfere a little bit late, you won't have any benefits. Maybe sparsentan works early on in early case of IgA nephropathy. Maybe in later cases, it would be exactly like in FSGS, wouldn't have that much effect.
So it's a matter of time regarding the effect of sparsentan.
Maybe the time of start,
Yes.
maybe.
And I believe that this is the same problem that we face with the steroids, because as I mentioned in the testing trial, this is the only trial when they have recruited patients with eGFR less than 30. There were 26 patients. And we don't know what is the outcome of those patients with eGFR less than 30. And I can say, to be honest, any of the IgA trial, they usually don't recruit a patient with eGFR less than 30, because it seems that those patients, they reach at the point of no return, probably.
Okay, thank you. A question from my dear friend, Professor Baha Zaid, is asking about salt and water retention with the use of sparsentan. Do you find it a major problem, and the mechanism behind it?
Yeah, it is a problem. By the way, it's not available as yet in the UK. Sparsentan. It's not available, but yes, it is one of the trial side effects. Yes.
Yes.
Yeah.
Significant side effects, and sure.
But it is not significant to the point to withdraw the drug. It's not significant to the point to stop the drug. The patient continued for the 110 week.
Yes. It is was the main side effects with these drugs with application in heart failure and some cardiorenal and something like this.
Yeah.
Professor Ahmed, do you have a final comment before we close?
Actually, as a part of the genetics of IgA nephropathy, how do we anticipate the recurrence in transplanted patients, and why we don't see specific genetic linkage, although it's very familiar, as you know, Professor Mohsen, like we see in other types, like, for example, in genetic FSGS, in steroid-resistant nephrotic syndrome, where you can search for a set of genes or specific mutations that can cause these types. Why it is not taken in this aspect in IgA nephropathy?
Simply because we don't have a single nucleotide mutation to say that this is the one is specific for IgA nephropathy. So that's why, not like, say, for example, of SGS. We know that in FSGS, that this specific nucleotide has got the risk factor or high, or this allele has a high risk factor for developing FSGS. And by the way, if it is purely genetic, contributing to that, the recurrence rate will be low, simply because you are removing the causative gene, which causes the trouble, unless the gene is in the circulation, like the complement, or like the HUS. If it is in the kidney itself, I doubt that there will be recurrence, but because it recurs, which means that it's less likely to be the genetic in the kidney causing the trouble, because you are removing the diseased or the sick gene from the diseased kidney. And when you are putting another kidney, unless this gene is in the circulation, which is probably yes, because all the alleles that they have discovered, nothing to do with the kidney, it's something to do with the methyltransferase of the galactose moiety. And this enzyme, whether there is some sort of aberrant mutation, something like this, making a defect in the galactose moiety deposition. So this is probably the reason.
Yeah, although there have been some studies pointing to the linkage with some of the HLA like DQB1 and
That's
DR1
true.
and
That is
as
true, but
well
it
as
is not the main thing.
yes, it's
That
an
is true, but it is
association
not
rather than yes. Again, some studies showed relation to the complement factor H and factor H receptor 1 and 3 and others, which explain, as you remember, our early studying of IgA, we differentiated IgA from post-infectious by the complement. We early on thought that complement is not affected in IgA nephropathy. Then it turns out that we measure IgA and C3 in the urine and divide them, and then all these seems to be nonsense. And now we approve the role of complement in IgA.
Interestingly, there are some case series where the complement in IgA is slightly reduced, and the prognosis of these cases was very poor. But it is not a common finding anyway. But I mean, there are some cases of IgA nephropathy when the complement is slightly low, C3 in particular, and the prognosis of those cases was very poor. But at the end of the day, it is not a phenomenon to say that the complement is reduced because it is usually normal.
Excellent.
Final comment from Dr. Mahmoud Sheikh, please.
Assalamu alaikum, dear our professors. Thank you, Dr. Mahmoud, for this elegant, holistic lecture and view. I have two comments about the prognostic and diagnostic value of serum IgA levels, which now are clearly mentioned in literature that IgA level in serum correlated with C3 and serum also may be a prognostic value for those with proteinuria lower than 1 gram. Also, for the intensity of immunofluorescence of IgA, it may predict the primary or secondary causes because of codominance of C3 with IgA. If it's C3 codominant or more dominant, will be with secondary cause like infections. If it's maybe dominant in primary cases.
Right. Thank you very much for this comment. First of all, obviously, with the complement and the proteinuria, if the proteinuria is a very simple test and you can do it easily, I believe that it might be more easy for the patients. And I don't know about the complement level that it can be as a predictor, because as I'm saying, the only available tool for prediction of the prognosis for the IgA nephropathy is the international predictor tool. Yes, even the Oxford classification doesn't predict. So this is one thing. The second point is about the complement
intensity of IgA C3.
To be honest, me myself, as far as I understand, there is no histological differentiation between the primary and the secondary cases of IgA nephropathy, except that when you see a case of suspected inflammatory bowel disease or liver cirrhosis or any of those coaches associated or psoriasis associated with IgA nephropathy, then please test the urine. If the urine is active for urinary sediment, then the biopsy might be indicated here. But I mean, to differentiate between both or any characteristic feature for the primary versus the secondary, I am not aware personally.
Thank you, dear Prof.
Thank you.
Thank you. We have no more comments and no more questions, and it's time to close. Professor Ahmed, please.
Okay, was a very interesting night, and many questions and many valuable inputs from Professor Mohsen Elkossi with a valuable lecture from all the discussants, Professor Amr Husseini, Professor Faisal, Professor Yasser, and our colleagues Khalid and Mahmoud and all other colleagues. We had very good discussions. We had very good clinical input. We have some insights in the upcoming drugs that we hope that it wouldn't be very much expensive, as the drugs nowadays are explosives in the prices. Any new drug is just over thousands of dollars and pounds. So hopefully that we can use them. And I would like to pose for a trial of using the old budesonide to try to find whether it's effective or not effective in our patients because it would differ a lot in the cost. Simply, we can use 2 tablets of the 9 milligram icosanoid that is present in Egypt for a very reasonable price. 2 tablets would be an 18 milligram. We can use it. We can find out what it can be, the effect, and look after. Thanks for the lecture. Thanks for the discussion. And hopefully we have more and more such valuable discussions for specific clinical syndromes in GN and other aspects of kidney diseases. Thanks, Professor Yasser, for gathering this very bright collection of the professors and colleagues. And bon nuit. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Professor Ahmed, for being with us and sharing your great clinical experience in this field, especially of glomerulonephritis and specific IgA, and special to Dr. Mohsen Elkossi for this very, very, very interesting, very elegant, and to the point, very comprehensive lecture. And a specific thanks again for your response to every question in a very simple way, illustrating the causes behind and the target of the question, targeting the question, the main bulk of the question, and responding to all of these questions. Thank you so much, and thank you for all professors who shared us, Professor Faisal Shaheen, Professor Husseini, and for all colleagues who shared and enriched this very, very specific session and very interesting session with their questions and answers. And we have many questions in the chat, but I can see that you answered it, Professor Mohsen. Professor Mohsen, where you are going on your speech and you are going on the discussions, you answer almost all of the questions in the chat, either directly or within your speech. Thank you for being with us this meeting and this meeting, and we hope to meet you in the coming meetings with Egyptian Society of Nephrology, CME chapter.
If someone would be thankful, it would be me, to be honest. Thank you very much for this opportunity to meet with my close friends and close colleagues. I feel very warm that I have been with all of you tonight. Really, I am very, very happy, apart from completely the lectures or any discussion or whatever it would be. I'm very grateful for that.
Thank you. And we are so happy to meet you all. You are always, and we hope to meet you nearly in person here in Inshallah. Thank you. And expect to close this session and announce about the coming session will be by Professor about pathology. In case-based discussions will be coming Wednesday at the same time, inshallah, 10 p.m. Cairo time. Please, we will go with our usual time, not with change with the summer time will be 9 p.m. Cairo time, even with the coming 1+ hour increase of our time. Thank you for all, and thank you, Professor Ahmed Al-Qurayshi.
Assalamu alaikum.
تصبحوا على خير.
وانتم بخير. السلام عليكم.